So huge welcome to everybody who's attending today, and we're talking about a career in clinical oncology, and hopefully over the next hour or so we're going to give you a little flavour about oncology. We're going to explain why it's the best career in the world, and of course this webinar is mainly focused on clinical oncology, but we do also have Dr. Satinder Jagdev, who's a representative from medical oncology, who will be available for the Q&A session at the end. So we're going to start off with the programme, which we're very pleased to have a great range of speakers. We've got Dr. Rubab Batul, who is the Royal College of Radiologists Oncology Registrars Forum co-chair, who's going to give you a talk about clinical oncology as a training programme. Then we've got Dr. Ruth Conroy, who's our national recruitment lead and a consultant clinical oncologist, who's going to talk about the recruitment process. And then we've got Dr. Sabreen Mohammed, who's going to talk about exploring ST3 applications, a personal perspective. And then we're going to have a Q&A session at the end, where we will be joined with Dr. Satinder Jagdev, medical oncologist, to provide expertise and address questions relating to the specialty. So please do raise questions using the Q&A tab. Hopefully you can find that. Just to ask the speakers to keep an eye on those so that we can reply to the questions as we go through the session, and we will be looking at Q&A at the end as well. So without further ado, I'm absolutely delighted to hand over to Dr. Rubab Batul, who is going to talk to you about clinical oncology as a training programme. Thank you.
Thank you, Lewis. Thank you very much. Hi, everyone. Thank you so much for joining us this evening. My name is Rubab Batul, and I am ST6 Clinical Oncology Registrar in Thames Valley region, and I'm also the co-chair of Royal College Oncology Representative Forum. So today I will be talking about my own personal journey about why I choose clinical oncology and what you will expect as a resident doctor whilst going through the training of the clinical oncology. So I will be not biased, not because I'm doing it, but this is generally the best specialty. So how I got into clinical oncology was I had a placement at when I was doing in medical school. I had a placement in oncology, and then oncology appealed to me. There are various reasons, and in this slide I'll talk about what appealed me and what appealed my colleagues as well, just to give a bit of broader perspective into why people choose clinical oncology. So when it came to me, the big impact on me was the cancer is a life-changing diagnosis, and I experienced this in my own family. I lost my mom to cancer, and that was the driving force for me to get into oncology. It's how much impact an oncologist can have on the patient outcome. It's life-changing. I don't really quite enjoying the procedures. I didn't never mind doing medical registrar, but my love for oncology outweighed the love for the gen med. And as I said, my personal experience was the main driving force behind for me getting into oncology. I did not know. I always wanted to be an oncologist, but I did not know the difference between medical oncology and clinical oncology. So when I got into CMT, and I chose all the grids stating oncology, and in that placement I got to know what's the difference between medical and clinical oncology is when one of the senior registrars, he introduced me to the beauty of the radiotherapy. And there, it was the first love. It was a love at the first sight. And because I always loved physics when I was at uni, and contouring now is my Zen place, it's very intellectually intriguing due to ongoing research. And also, when you are planning a radiotherapy, you have two sides of radiotherapy, palliative and the radical. And you can actually, in palliative, you can actually see, it's pretty intriguing what you want to cover in palliative radiotherapy. It's a pretty Zen place. So I only applied to clinical oncology, and I thought long and pretty hard about it. And yes, CEO was the answer. So I only applied to clinical oncology. And I always feel that communication is such a part and parcel of our own lives. Like, because I was across the table many moons ago, so I could actually get in touch with the human that is sitting across the table. And I think as an oncologist, it's imperative to get in touch with the human that is sitting across the table, to tap into the emotional realm of the person that is sitting across the table. And I take my own position very spiritually, and I'm very grateful to be on this side of the table. And just because I was a patient's family many moons ago gives me a broader perspective of being an oncologist. So now talking about the clinical oncology training pathway, we have ST3 to ST4, then ST5, 6, and 7. Now progression into the ST3, it's a ST3 to ST4 now is a common oncology STEM. And then in common oncology STEM, we will learn both. The medoncs will learn about the palliative radiotherapy. Of course, as a clinical oncologist, we do both as a the chemotherapy part as well, and as well as the radiotherapy part. And from ST4 onwards till ST7 is the clinical oncology specialty training. And from ST4 to ST5, we will be doing a part exam, which is called FRCR Part 1 exam. I'll be talking about this exam a bit later. So there will be like Part 1 exam. Registrars need to have this exam completed before progressing to ST5. And then from ST6 to 7, there is another part which is called Part 2A, written, and 2B, Viva, before progressing to ST7. It's more like an MRCP, 2 written, and then 1 is the OSCE type, the final one. And then normally people take time out between ST5 to ST6 years because you can't take a year out in ST7. So people normally take time out for fellowship and leadership. Nowadays, they're more interested in AI, MD research degrees. There are a lot of opportunities. The TPDs are very, very supportive of people taking time out. So this is the time out, and ST7 is the last year before CCT. And in the last years, people normally act up, so they're more confident when they become consultants. How a typical week looks like is radiotherapy clinics and the planning time. We have new and the follow-up clinics. We have on-calls. The on-calls are totally different than the GenMed on-calls. Some people do, they are like, so the on-calls are like into the day on-calls and the night on-calls. The night on-calls, most of the places do the non-resident on-calls, but we do have the resident on-calls as well in some parts of the country. They are no way as brutal as the GenMed, and they are very manageable. We have ward inpatient reviews, the ward rounds. Then we have mandatory teaching weekly as well as monthly regional teaching days as well. And then we attend MDTs as well. This is a typical week in a full-time looks like. This is a sample job plan. Recently on the RCR website, we have published a sample job plan and to help the residents plan their work when they are working in the clinical oncology. And this is just to make sure that residents are doing what they're supposed to do and nobody's doing extra work, compromising their training. And this is just a sample, and there are sample work plans as well on the document. So please do check out that document if you're interested in the clinical oncology. In terms of in the coming slides, there are some examples of less than full-time training as well. Next slide, please. Yes. So in the less than full-time training, the full-time normally do 4 to 5 clinics, and then the rest of the time is split between MDTs, radiotherapy planning, admin planning, and inpatient ward reviews. We do have an opportunity and flexibility of working from home as well in exceptional circumstances, and TPDs are very much happy to discuss this option as well. I work less than full time, and this gives me a brilliant work-life balance. I work 60%, but in the job plan we have the job plan samples are for 80% and 60% as well. In 80 to 60%, you do 3 to 2 clinics a week and MDT, admin, teaching, and yeah. So in all the job plan samples, one thing we ensure is we have enough time for the radiotherapy planning. And in the next slide, so in terms of now the courses and the teaching available, we are very much aware that this is as an ST3 because in clinical oncology, even in medical oncology, there is a new language you are learning. You are at the top of your medical career and now you are going in, getting into a specialty and you're learning a whole new language. So there are courses, there are brilliant courses to support these courses. There is a funding as well when it comes to attending the courses, the study budget. There is a self-study leave as well prior to exams. For every type of exam, you can get up to 5 study days. Regional teaching days, which are brilliant to catch up with the other sites in terms of because cancer is an ever-evolving field. So regional teaching days are a brilliant way to get in to keep ourselves updated. Then there's a local teaching as well in one of the afternoons. And RCR website, they have recently revamped the site and there are some very informative and brilliant resources on the RCR website. When it comes to the part one questions, RCR question, there is an RCR question bank, which I found very helpful when I was preparing for my part one exam. And there are always in your hospital, there are consultants, there are senior colleagues, there are brilliant radiographers, physicists, they're very happy to teach. And I feel I am an intern, so I have done my training half in Birmingham and half in Oxford. And I feel, and I have rotated across West Midland. And what I have found is clinical oncologists are very friendly people to approach and physicists and radiographers. Everybody is so open to answer questions and teach as well. The next slide, please. And this is the final FRCR examination. So after part one, we need to, as I said, we need to complete by the end of ST4. There are four modules in the part one: cancer biology, clinical pharmacology, medical statistics, and physics. People are mostly get intimidated when they hear the name of physics. I have a lot of colleagues who have never done physics in their O levels, but they are excelling in the clinical oncology. And this is because we have the physicists, radiographers, and they're so friendly to teach. There are some local courses as well to help bridge the gap. And then we have FRCR part two. This is more like MRCP part two, but more speciality directed. And then a final OSCE part. And this is me recently attending my FRCR ceremony this Friday after a long journey. There are a few things which I want to mention. Like when I was speaking to my three colleagues and then what apprehension and what they were worried about when they were coming to clinical oncology was people been telling them, oh, there are a lot of exams. The exams are difficult. So when I asked this question to one of my colleagues, he answered me very beautifully. He's like, don't look at the 5 years. Look beyond those 5 years. So how your life would be, how you want to imagine yourself. One of our consultants told me, choose a specialty by imagining yourself that you are 60 and now you are picking up a specialty, something that you would like to continue at the age of 60 and afterwards as well. And don't get scared by the exam. Lots of people have done it. There's plenty of support around. Clinical oncology consultants remember their own time when they were going through the exams. So they support you as much as they can. There's a lot of support around. And look at the broader picture as well. When it comes to selecting a college, I never realized, but now I realize this is a big impact. This creates a big impact. The college you affiliate with, now I feel like it should help you excelling, give you enough leadership qualities, help you expand. And Royal College of Radiologists is a brilliant college to work with. Yes, and whenever at any point you feel like burnout, you are tired, don't look how far you need to go. Always look how far you have come. And this puts you in another perspective. This will give you a broader perspective. Never deny our specialty based on how difficult the exams will be. If there is a will, there will be a way. Just pick up and don't be scared of the exam. Don't be scared of the exam. And this is what from my side. If you have any questions, I'm happy to be contacted. This again, I'm saying if I could do it with the kids, with the family, many of my colleagues have done it, so you will be able to do it as well. So don't let exams stop you from opting clinical oncology as a specialty. And that is it from my side. If any questions, I'm happy to be answered. And Jackie has my email address as well. If somebody wants to reach out to me personally, I'm more than happy to talk. Thank you, Louise.
Thank you. Thank you very much, Rubab, for that insight into life as a resident doctor in clinical oncology. Can I remind people to use the Q&A tab as needed? We'll move on to the next talk. So Dr. Ruth Conroy is a consultant clinical oncologist. She's the national recruitment lead. I work alongside Ruth very closely. My name is Louise Hanna, and I'm a consultant clinical oncologist in Cardiff, and I'm the medical director for education and training for clinical oncology in the Royal College of Radiologists. So we work very closely together with regard to national recruitment, and I'm going to hand over to Ruth now. Thank you.
Thanks, Louise. So yeah, I'm Ruth Conroy. I'm a clinical oncologist up in Manchester at the Christie. I'm also the training programme director here in the Northwest. So, happy to kind of take questions, or people can email if any people are interested in any particulars about training in the Northwest. Please don't hesitate to get in touch. So I suspect a lot of you may be aware now of kind of important dates for the diary. This is all available online, so nothing that I'm telling you today is kind of special or unique. So obviously the session is being recorded, but it is all available out there for you. But just to try and kind of get everything together in a neat package, the round 2 is the first round of specialty training recruitment, because round 1 is only for IMT, basically. So it always sounds a bit confusing that round 2 is our first round. And that starts next month. The vacancies are due to be published, and then you'll have to get applications in by approximately mid-December, and then we'll be interviewing in March. I've got the specific dates in a minute, but it's just to give people a guide. And so those jobs will be starting in August 2026 for the majority of them. And then the round after that, if people aren't quite ready yet for whatever reason, round 3 will be to start recruitment in kind of February, March 2027. And we look at opening those kind of mid-July-ish. So applications close by mid-August, and then we're usually interviewing around October time. So just so people are aware. If we can have the next slide, please. I think we've got the exact dates for the round. Yeah, so 19th of November the vacancies will be published, and what I would strongly recommend is don't be put off if you're desperate to only work in one particular place, because as a training program director, we have to give indicative numbers, and we're asked for those numbers very early on, and sometimes things can change. So you may think you don't have a number and suddenly you do. So I wouldn't be put off if you don't think there's a vacancy in the location that you want. I would strongly urge everyone to apply. So the application window opens on the 20th of November and it closes on the 11th of December. And then you've got plenty of time to upload evidence, and we'll talk about evidence in a second. And then the invites will go out on the 2nd of March, and it's basically a first come, first serve, really. So we encourage people to get online early and make sure you get an interview date and time that's going to work for you. And then we're going to be interviewing on the 23rd and the 24th of March, and the offers will likely be released kind of early April time. So that's what we're looking for the next round, to start those jobs in August 2026. And they are still proposed dates, but it's very unlikely at this stage that they're going to change, to be honest. So next slide, please. So in terms of who can apply, basically you need to be able to demonstrate IMT2 capabilities. So we expect you at the level of, in old money kind of SHO before you apply. So you don't have to have done IMT3. We don't expect kind of more senior general medical competencies. It's IMT2 that we're looking for, and you need to be able to have completed your MRCP by the time that the offers come out. So if we think about the next round, the job offers will come out in April. So you need to have time to have fully completed all parts of the MRCP by then. So for example, if you've not sat any of it yet, you're probably a bit tight in terms of dates and sittings to be able to get all of it. So just check the dates and make sure you don't have to have all of it by the time you're filling the application in next month, but you just have to know that maybe if you've just not sat paces yet, that you've got time to at least sit paces and obviously hopefully pass it. Likewise, it doesn't have to just be IMT training. It's about demonstrating the capabilities that we expect at the end of IMT2. So some people will have done training in Ireland. Obviously, lots of people will have done training in different places over the world as well. So there is paperwork that you can complete to demonstrate that you are at the right level. So don't be put off if you haven't necessarily done your training in the UK as well. We're just looking at making sure you can demonstrate the right level of capability. Next slide, please. Sorry, I should have said in that last slide that, yeah, we do aim to interview everyone. We appreciate the application forms are really helpful and the self-assessment is really helpful. But some people maybe don't always know how to sell themselves at the best or have had different opportunities, and it doesn't mean you can't be an excellent clinical oncologist. So please do apply. And as long as we have the capacity, we always try to interview everyone. And so far we've been able to do that every year. So focusing on the self-assessment for a minute, this forms about 15% of your overall score. It's very similar to the majority of physician specialties, but what you'll notice if you look is that you will score higher if something is directly related to oncology. For example, if you've completed an audit cycle and that audit happened to be an oncology related subject, you'll score slightly higher than if it was non-oncology. Please make sure that you put evidence for everything that you score. We don't need to see 200 pages of evidence because that's just kind of overwhelming. But if you've put something down there that you say, I've scored for an audit, for example, we need to see that audit. It's quite difficult for us to score you if you just have a 2-line letter from maybe a supervising consultant that just says, yes, Dr. X completed an audit, because we need to know more. We need to know, well, what did you actually do? How did it change practice? What was the impact? What was your role in it and things? So please, do try and provide evidence for everything. All the scores are checked by a consultant clinical oncologist who obviously tries to be fair and transparent and wants you to do well, wants you to score appropriately for everything that you provided evidence for. But if there are any concerns, you do have a right to appeal, and then myself and the deputy lead will always look through everything and make sure that you've been given the score that's the fair score for you. If you're worried that maybe you won't score very highly, maybe you've not had the opportunity to do lots of audits or research or things, please don't let that put you off, because as you can see here, it only scores 15% of the overall mark. So you could still be an excellent clinical oncologist even if you maybe don't score super highly at this stage. So I would really encourage you still to apply. That doesn't mean you have to try and make things up to put on your self-assessment score. You can just score yourself a 0, and as I say, we will still always try and interview people if we can, so please don't be put off. You can see the form online now before you have to score, so I would encourage everyone kind of after this meeting to go away and have a little look at things, because there are some things that you still have time to get yourself a mark for, even between now and November. There's things that you can do to get experience in, say, teaching. For example, there is still time with only kind of a month away before things open. Next slide, please. So One difference this year is that in the past we scored people on how much of the MRCP they'd already completed. You won't be scored for that now. Obviously, as I said, you will have to have the full MRCP or MRCPI by the time that you get a job offer, but you don't get any scores for having done parts of it at this stage. You are scored on whether you've got any postgraduate degrees and qualifications, any presentations or posters, publications, teaching experience, but also training in teaching. And you do get a score if you've done even a couple of days training in teaching. So, certainly that's one thing there's still time for. Quality improvement and leadership scores as well. So as I say, that's the link there, but if you can Google clinical oncology ST3 self-assessment guidance and it will give you much more detail about each of those criteria and how you can score for each one. So I'd encourage you to have a look sooner rather than later at that, please. Next slide. So as I say, we try and interview everyone as long as we have capacity. All the interviews are virtual interviews. We don't do any face-to-face interviews. So please make sure that you have a good internet connection. As I say, once the interviews are released, you can go on and pick your date. So the sooner you do that, the better, and try to make sure that it's one of those days and times that you can get a good internet connection, because we know sometimes the hospital internet isn't always the best. So please do try and make sure that you assess that in advance. The interviews have 3 stations, and at each station you'll have two people who are scoring you. So there'll be a clinical station where there's 2 5-minute clinical questions. Then there's more of an ethics/governance station where, again, there'll be just 2 5-minute questions, but you do get a mark there as well for your general communication skills. And then the 3rd station will be questions about your portfolio and experience to date. You could start on any of these. You won't necessarily run through them in any set order. And we're assessing you at the level of someone at the end of IMT2. So we don't expect you to be at the level of a clinical oncology middle grade kind of doctor. We know that a lot of people at this level may have had very limited contact with oncology. So we're not expecting super specialist knowledge. It's really important to be aware NHS England have just published a statement on this, that obviously we don't allow the use of artificial intelligence during the interviews. We want to hear what you've got to say and how you'd manage the situations. Next slide, please. Obviously, I can't share all the questions with you in advance, but if you think about clinical scenarios, these are often very common clinical scenarios that you might come across. Thinking that you're end of IMT2 or you've just started an ST3 job. So usually it's maybe an oncology patient is unwell, or perhaps someone has a suspected cancer. Think about common oncological emergencies. So how might you manage a malignant spinal cord compression, febrile neutropenia, hypercalcemia, brain metastases, just things that are quite common in lots of medical specialties, not just oncology. And often we'll be asking you to just tell us a bit about how you'd approach the patient, possible diagnoses, beginning to formulate a management plan. As I say, not necessarily having all the specifics. We don't want to know about doses of radiotherapy that you'd give or chemotherapy drugs you'd give, etc. It's just a very broad overview of how you'd kind of approach someone who would be unwell. Next slide, please. The ethical scenarios, again, just bear in mind, these are often things that we might expect you to have already come across within your training so far. So we might ask about consent. So whether that's asking you to consent for something that you didn't feel perhaps ready to consent for, or thinking about talking to patients and family and getting consent. We might talk about quite difficult situations like resuscitation discussions, or perhaps feeding discussions if people are no longer able to manage food orally. It could be slightly different. It could be about concerns about a colleague, thinking about, you as a general doctor becoming a more senior member of the team, having that eye on other colleagues in the team. Might be about capacity. Do you know how to assess capacity? Do you know any of the legality around it? And then it could be breaking bad news. Can you demonstrate, how you would do that in a sensitive manner? So there's lots of things, but none of them should hopefully be beyond anyone. As I say, these are not. We're not trying to catch you out. These are general things that you would come across all the time in your job as a doctor. Next slide, please. And the portfolio. We obviously think clinical oncology is a fantastic career choice. Everyone that is interviewing you will be a clinical oncology consultant or a senior resident doctor, so kind of ST6, ST7. We want to know that you feel the same, and this is something that you want to do. So the fact that you're here on this webinar is great. The questions are very, very broad. There will be a question, along the lines of why do you want to do clinical oncology? So if you can show us why, show us that you've researched it, tell us about the fact that you came on this webinar, that you've talked to colleagues. We appreciate that you might not be able to go and get time on a radiotherapy machine, but oncologists, we kind of get everywhere. We're in every MDT, there's specialist nurses everywhere, so there's lots of people that you can talk to. Reach out to people after the webinar today. Please look on the website. There's so much information on the RCR website so that you can demonstrate that you've had a look, you understand there are exams, you understand there's radiotherapy aspects, there's systemic anti-cancer aspects. There's a lot of information that you can get, even if you haven't had a rotation that's necessarily been spent in an oncology department. You can still show that you're keen and that you're interested. So please talk to people. Next slide, please. So yeah, things that you can do now. You've got a month. So talk to us. You're here, ask questions now. You can ask questions offline and say, we're happy to be contacted. Talk to resident doctors that are around. Talk to training program directors and say, I'm more than happy to be contacted, whether it's something specific about the Northwest or elsewhere. But if you look on your local NHS England website, they will have contact details for your local training program director if you've got specific questions. And as I say, please look at the website, because at the end of the day, we don't want to catch you out. We want interested, keen colleagues to come and join us in this specialty. So the more keen, bright people we have, the better. So please, talk to people, get as much information as you can kind of in preparation, and hopefully you'll be able to join us soon. And that's just a little slide of the some of our resident doctors and RCR staff for the annual trainee oncology meeting that was at the Christie. This year we were lucky enough to play host, and next year I think it's in Birmingham. So hopefully many of you can be joining that conference in the future. Thank you very much.
Thank you very much, Ruth, for that great insight into the application process. I think what we're going to do now, we're just going to pop back to Rubab, who is going to talk about the Oncology Registrars Forum, and then we'll move on to the next speaker after that. Thank you. And just a reminder to everybody to use the Q&A. There are quite a few questions in the Q&A there. We've started to answer those, so please do use that. And over to you, Rubab.
Thank you very much, Lewis. Thank you. So with regards to the opportunities of getting involved with the college, is one of the fantastic forum is the Oncology Registrars Forum. This forum has got representatives from all across the UK. It's a resident doctor voice. What we do is we discuss the best practice, we flag any issues and concerns, and we create a network of the colleagues. As a co-chairs, we have 3 weekly meetings with Lewis where we discuss the concerns that's been raised by the reps across the UK, so we don't have to wait for the 6 monthly meeting. And we are very proud to say that the residents' voice is very much heard at the college level. And with the committee. So normally you have the sorry, you have two co-chairs. This time it's me and the David, who is from Northern Ireland, and then you have representatives from across the UK. It's a fantastic networking team. It's a fantastic networking opportunity. And with regards to the other opportunities, is one of the other brilliant opportunity is the Atom, which is like a fantastic team networking Atom. The next one, as Ruth said, it's going to be in Birmingham. And I think the date is on 10th of May, if I'm not wrong. Yes. So I'm hoping to see you, as many of you, at Atom. And in terms of the further opportunities at the college, so nowadays AI is a hot topic, and the college is doing a lot of stuff in terms of training, clinical work, publishing guidelines, research, management of guideline management for various radiotherapy, guideline and management of the various cancer regimes, artificial intelligence. A lot of work has been going on at the college. So there are a lot of plenty of opportunities to get involved at the college level to expand yourself and your leadership opportunities. Final word with regards to the clinical oncology, it's a sustainable career. There's always going to be work. Anybody who comes and tells you that there will be shortage of consultants, there will be no jobs for the consultant in the future. Royal College is doing a lot of work to increase and expand the places for the consultants. We need more resident doctors and we need more consultants. The recent RCR census has shown that there is a deficiency of the workforce at the ground level. So RCR has been campaigning to increase the number of the training spots and as well as the consultants. You have an opportunity to work full-time, less than full-time, work from home as well. And on-calls are very manageable. It's a family-friendly specialty, and the board work and the on-calls are manageable as well. If you have any questions, please talk to the residents, talk to the consultants. We are very happy to talk. We're generally very happy to talk and give guidance to. And yeah, if there's any question, I'm very happy to answer.
Thank you very much, Rubab. So I think what we're hearing today is, oncology is a really patient-focused specialty, and we really use cutting-edge research technology to continually improve our treatments and how we can, the treatments that we can offer. You do get taught. So particularly during your first year, you get dedicated teaching on everything that you're going to be examined in the Part 1 exam. And so, you don't need to be an Einstein in order to pass the Part 1. A lot of us have not done physics A-level. I did not do physics A-level, but all the physics that you learn is really very, very clinically relevant. That's the important thing. And what you get taught, the teaching sessions that you have, they really give you a really strong foundation. Like Rubab was saying, it really sets you in good stead for the rest of your career, and you use those principles every day really with what you do. So it's a fantastic specialty. We're going to move on to our next speaker now, who's Dr. Sabreen Mohammed, who is going to talk about exploring ST3 applications, a personal perspective of clinical oncology at ST3. So thank you very much, and over to you, Sabreen.
Hello, good evening, everyone. I am Sabreen. I am one of the Scotland trainees. I'm based at Beatson. I started my training just last February at round 3. I'm happy to share my experience, as I feel it will help lots of people with different background. I haven't came through, and I will be speaking about that through the coming few minutes. So what we are going to speak about tonight is the application and interview process, steps for preparing to apply, and then I will just mention what my colleagues has mentioned previously, just reflecting that on my personal experience and the interview process regarding how I prepared myself in this regard. Next slide, please. So my sincere advice will be plan ahead, begin early as possible, and seek guidance from colleagues in clinical oncology training. Keep asking around and reach out, and every person is happy to help. So what I have done as a head plan to prepare myself to join clinical oncology training, I arranged a tester week. I was working as a trust grade medical registrar in the Midland. I emailed the department and they were happy to arrange for me a tester week on which I got the opportunity to explore regarding the radiotherapy planning, and I spent time with the radiographers and physicists. I also attend a couple of clinics on which I explored the new clinics for the new patients and also the SAT clinics. I have attended few of their MDTs as well as joined ward rounds to see the all areas that is covered by the clinical oncologist. As I mentioned, I came from different background. I came from overseas, and I was in Saudi Arabia for a long time. I did my audit and QIB over there, and I brought my evidence with me. In terms of research, I haven't done research myself. I participate with my colleagues as data collectors, but I got a good insight how the research are built. And I reach out to few of the clinical oncology registrars with which I have few chats regarding the training, the role of the clinical oncology, the difference between clinical oncology and medical oncology to decide which one I'm interested with. And I started ahead with my application. So the normal pathway for training is to finish your foundation, then to go through the IMT training, to join the clinical oncology training. However, as I did a lot of training as overseas, and I had my competencies signed for the level of IMT2, I haven't went through the process of IMT. I just showed my evidence and I got my alternative certificate for Group 2 specialties signed, and this was the evidence that I shared with my application. Next slide, please. So, as I mentioned, I have applied the previous diet, and I gained my marking through this slide. So there were marks for the MRCB UK, which were 8 points. I think they are now not on the self-assessment. And for the postgraduate degrees, I haven't scored any point, as well as the prizes or any prizes as post or pre-graduate. However, for posters and presentations, I had my evidence for national presentation, which gave me the highest score. And also I have scored the highest score for teaching experience. Since I joined my hospital as a medical registrar, I joined the teaching team for the medical students, and that was for a whole year. I prepared teaching sessions and organized them, and that was a great score for me. For training in teaching, I have done 3 months course for teaching, and that gave me good score as well. And all of these gave me good score and eligibility to go for the interview process. In terms of the self-assessment, what my advice is to avoid overscoring, review all scoring components thoroughly, and choose which one will give you the appropriate score. If you got time, consider projects beyond the medical field. I showed evidence for leadership, which was as a manager for a magazine. So it's totally non-medical related, but it gave me a good score. Participate in the quality improvement projects and get the leadership role, which will give you a good score as well. And ensure sufficient supporting evidence that the one you are using for your scoring. Because if your role is not mentioned clearly, you will struggle to get the score that you are aimed to. Next slide, please. So after I ensure that I'm eligible, and after I achieved a good score that put me on the process for interview, then I familiarized myself with the interview, what does it include, and what are the stations to plan for the interview in a good way. The interview, as it mentioned before, there are two big stations. In the first station, there are two clinical scenarios, and there are two ethical scenarios. And on this station, you will be marked for a whole communication skills. Then the portfolio station, on which you will show your commitment to the specialty. And to achieve a high score in the commitment to specialty, it will be appropriate to show different exposure to specialty, as to do a tester week, attending different conferences, do an audit or quality improvement project related to the clinical oncology. And also you can mention your personal qualities. The interview was conducted online, and each station was 5 minutes, and was involved 2 consultants as panelists. So in terms of the clinical and ethical stations, each scenario was 5 minutes long. Make sure that you have clear structure on approaching the scenario. Focus on delivering the most important information while demonstrating safety and reliability. And practice and right practice is the key. I used the acute oncology book for preparing for the oncology emergencies, and I made my structured approach for how to deliver the most important information for each scenario. I contacted some of the clinical oncology registrars that I reached to, and I just asked them to do for me some mock interviews, and they were very helpful to do that, which gave me the confidence when I went to my interview. Next slide, please. For the portfolio station, please be familiar with your portfolio inside and out, and do not hesitate to highlight your strengths. And don't be shy to sell yourself confidently. Make sure to research and talk to others about the training pathway. Choose something you are genuinely proud of from your portfolio to discuss, and if this is related to the clinical oncology as a specialty, this will be really great. Next slide, please. So my sincere advice, start as early as possible, reach out, keep asking, show your commitment, and for sure you will get your post. I'm happy to be contacted at my email address, which is sabreen.mohammed@nhs.scot. And if there is any question, please get in touch.
Thank you very much, Sabrine. That was really helpful. Hopefully, people have picked up some. Sorry, my microphone was up there. Thanks so much, Sabrine. That was really, really helpful. Hopefully, people have picked up some really good pointers there to support their application. I think what we're going to do now, we're aiming to go on to the Q&A session. So we've got all our speakers here who should be able to help with answering some of the questions. There are quite a lot of questions in the Q&A tab, but we have made a start at answering those. I think we have Michael here who's going to read out the questions. Is that correct? Are you there, Michael?
Correct. I am, Louise. Just one second. Put my camera back on so you can see me.
Lovely. Thank you so much. Right. And we've got Satinder here, Dr. Satinder Jagdev from Medical Oncology as well, who can answer any questions about medical oncology. So, are you able to fire away with the questions then, Michael? Thank you.
Right, here's a very good question. How do we see AI changing the practice of clinical oncology?
That's an amazing question. That's a good one to start off with.
Herculean one.
Yes. I mean, I'm happy to start off with that one if anyone wants to chip in. So, I mean, we do feel that AI is going to sort of revolutionize the way we practice, but there will always be the need for clinical and medical oncologists. We do know that patients do like that human interaction, but AI can certainly help us with various things from planning treatments, diagnosis, and also, to maybe aid with precision making, treatment choices, that kind of thing. And we also hope that AI might help with administrative tasks, maybe streamlining MDTs in the future as well. So there's a vast range of things that AI can potentially help with. We do actually have an AI conference. The RCR is holding an AI conference in the future, so do check out the website if you're interested in AI and come and join us in that. Does anybody want to add anything more?
I think just to say that we'll never be unemployed. I think AI will only ever be in addition to the humans. So I don't worry about applying for the specialty and thinking you'll be made redundant in a few years. I don't foresee that will be happening.
Absolutely. Thank you.
Next question. Can IMGs get into internal medicine training via the MSRA exams before proceeding for MRCP?
Ruth or Satinder, are you able to answer that one?
I guess just say that's a bit kind of outside of this webinar, really, applying for IMT training. I don't know all the ins and outs of IMT training, but you wouldn't necessarily have to do IMT training if you already felt that you'd met the competencies, because I think there was another question about the competency pathway. So there's lots of information out there online, and basically there's a form that you need to get filled in that shows that you've met the appropriate capabilities. I don't know if Satinder might know more about IMT than I do.
Yeah, no, I mean, again, I agree with you, Ruth. That's really outside of the remit of this webinar regarding specialty training. But really, if you go to the JRC PTB website, which is the training website for the Royal College of Physicians, where IMT goes through, you'll be able to get more information on that, certainly, and you can contact the team at the JRC PTB as well.
Thank you.
Another good question is from somebody, just to confirm, does every applicant receive an invitation to interview, or is there a score cut-off?
So we try and invite everyone to interview. That's why we really encourage everyone to apply, even if you think you won't score very highly. So unless we're completely inundated and we can't fit in everybody for interview over the 2 days, in which case we'll have to create a score cut-off. But at the moment, we're very, very keen to interview everyone, and so far we've always been able to do that.
Could you expand more on how working from home would work during residency training?
So working from home, basically, obviously since COVID, quite a lot of people do work from home. It would be a matter of discussing it with your training program director, with your supervisors. Obviously, for things like on-call, clinics, etc., they do need to be done face-to-face, but there is often the possibility of some part of the timetable being a working from home session. I don't know if you want to add more to that, Rubab.
So, thank you so much, Lewis. So there is a complete guided, there's a detailed document on the RCR website by the name of the RCR Resident Job Planning section. So we have recently updated it. When we say work from home, it's in some situations which, as Lewis said, you need to discuss with your TPDs. The part of the things that you could do remotely is the multi-MDTs, which most of them are not virtual, or some parts of planning aspects, but it's at the discretion of the TPD. You need to speak to the TPD. So yes. So, but for the more detailed in terms of explanation, there is a document on the RCR website which we have recently updated, and it's been published on RCR now.
And I guess I'd just say with my TPD hat on, sorry, Louise, is that, yeah, certainly since the document's been published, this is something that we're hoping to be able to incorporate so that all resident doctors can maybe have at least one session a week where they're able to work from home, possibly an admin session, possibly kind of MDT. But I think it's fair to say, you know, there's possibly more flexibility in clinical oncology than maybe some other specialties. Yeah. And I think people are keen to support this. As Louise says, post-COVID, you know, everyone is used to working a bit more remotely. So generally, you know, people are supportive as long as making sure that obviously everything is kind of safe and covered in the hospital.
Thanks very much. We sometimes get a question on medical oncology and clinical oncology. I can't see one here, no. But obviously we've got Satinder on the call. I don't know if I can call on Satinder just to give a little overview about medical oncology for anybody that might be interested.
Yeah, absolutely. No, I'm happy to do that. And Jackie also has some details of a parallel webinar that we'll be doing with Louise on board as well in the coming weeks. But just to explain, so we have, in terms of the structure of medical oncology training and medical oncology as a specialty, so we focus on the systemic anti-cancer therapy aspect of it. So that is the chemotherapy drugs, immunotherapy, cellular therapies, etc. So we, in terms of the training, both clinical and medical oncology residents would do the oncology common STEM, which really brings out the commonality of both our specialties. So we work very closely together in the MDT, and the aspects like experience of radiotherapy, because we are going to be working in the MDT, acute oncology, and some SACT competencies. They all come into that common STEM, and then the training really diverges, so that there's the radiotherapy focus for clinical oncology, and for the medical oncologists there's a focus on, as I said, different types of systemic anti-cancer therapies for the tumor types. There is a focus on intensive therapies as well, therapies for rarer cancers, and really, we're very much involved in bringing new drugs and new technologies to the clinic, and it's a very rapidly changing specialty. And I think on both sides, there's a lot of research going on, both on the radiotherapy side and on the anti-cancer therapies side. So that's a very exciting part of what we do as medical oncologists. In terms of other differences between the training, we do have an exam. We have one exam, which again, you'll hear more detail if you join us on the 10th of November, but we also, our training is shorter. So we have ST3 to ST6, so we have a 4-year training. Happy to take any questions about any of that, really.
Thank
Cinda,
you.
there's a question in the chat that might be well placed for you. So that says, if I didn't manage to pass the exams during clinical oncology, so the FRCR, can I apply for medical oncology? Will it be a shorter training time in medical oncology based on having done some years in clinical oncology?
So I think, again, like clinical oncology, we have a kind of process in terms of the applications, and we would really want to know that, it wasn't a default change, but you wanted to do medical oncology also for the sake of becoming a medical oncologist. So that's an important thing to note. But in terms of there are commonalities in the training, and if you were to gain a post in medical oncology, then at ARCP, your clinical oncology experience would be looked at, and then decisions made on an individual basis as to how much of that would count towards your training as a medical oncologist.
Thank you. That's great. And there's also a question there, between medical and clinical oncology, how do proportions of on-call, inpatient ward rounds and nights differ? I would say they're pretty similar, actually. Our medical and clinical oncology resident doctors actually are on the same on-call rota, so it's pretty much identical, really. So
I would agree. Yeah, I think you'll find in most places the resident doctors are on a joint on a joint rota, and they'll work in parallel. So I think there's not a lot of difference in the out of hours work.
Yeah, thank you. I can see Jackie's put the slide up about the webinar in medical oncology there, a career in medical oncology on the 10th of November. So put that date in your diaries. Michael, do we have any more questions?
There's an interesting one here. How different is clinical oncology training between different deaneries? My interest lies in learning both systemic and radiotherapy, but I've heard depending on where you train, your exposure to systemic therapies may be quite limited.
Okay, so clinical oncology obviously trains in systemic therapies and radiotherapy. So that's in the curriculum, so there does need to be exposure to that. I don't know if you want to add any more to that, Ruth.
Yeah, because I think there's a couple of questions around this further down as well. I think what you'll find is that actually you get very good exposure in both everywhere. And I might be fair to say, I think sometimes people worry that actually they get more systemic exposure than radiotherapy. And that's one of the really helpful things about the new job plans that have come out, to make sure that everyone gets sufficient radiotherapy planning time. The other thing was, I think, the comments about different deaneries and study leave. So all resident doctors in the UK get given the same study budget. So officially there isn't a limit on that, but obviously there's not a never-ending kind of pot of money. So the TPD in each kind of location will have had to say what are the essential courses that the resident doctors in clinical need to go on, and what are some desirable courses, and those will be funded So it's a bit concerning if people are saying that they don't get any study funding. What does happen in some places is that the training program director can kind of top slice. So for example, at the Christie, I can top slice the study budget to say we're going to run a part 1 course, and therefore my resident doctors that need to sit for the part 1 course don't have to pay because it's paid for already, so they don't have to claim it and refund it and things. So that could be maybe what's happening in some places. People aren't aware that it's essentially already been taken out of their study budget and paid in advance for them. But all resident doctors in the UK are entitled to a study budget, and the TPD kind of will govern that alongside NHSE and the resident doctors.
Thank you. Any others, Michael?
One around exams. How many attempts can you have at the FRCR exams?
So that one is generally 6. I think I have answered that one with a comment, and I put a link to the web page where you can see the number of exams that you can take, but generally speaking, that's 6.
I think the others have been answered.
So I think one's just popped in there about research. So I think I would say that we're, lots and lots of people either take time out to do research or are heavily involved in research throughout the training program. So some people will apply for an ACF post, so an academic clinical fellowship post that's done slightly separately, kind of alongside the national recruitment. Lots of other resident doctors will start out their training and then decide that it's something they're interested in later on. So the most common time period that people go out of programme for research is in their ST6 after they've completed their FRCR Part 2. But some residents do it other times as well. And that's just something that if you're interested in it, talk to your educational supervisor early on so that you can both liaise with the training programme director to work out kind of appropriate times. And I think it's probably fair to say that's very similar for medical oncology as well. I think both specialties really encourage kind of time out and research and getting interested in lots of different things.
Yeah, absolutely. I'd agree with that, Ruth. I think, medical oncology started out as an academic specialty, so many of our residents will get involved in certainly research on a day-to-day basis, but also have opportunities to go out of programme. And again, as you've said, apart from taking time out to do research, there are opportunities to do clinical leadership, there's opportunities to do education fellow posts, there's lots of opportunity to gain experience elsewhere. So really lots of opportunity to tailor the programme to your needs and your interests.
There's a question here also about at what point can you apply for less than full-time? Is it at the start of the application process or only after you have received an offer?
Want me to take that one? Sorry. So you can state a preference straight away, but yeah, as soon as you get your offer, you will need to kind of formally apply for it. And once you've started your training, there are, I can't remember now if it's 2 or 3 windows a year, so you don't have to go in full time and then you can never go less than full time, or vice versa if you went in less than full time and wanted to switch back. So you have to give at least 16 weeks notice before your next rotation, basically. So the window's just closed now for kind of February rotations. But yeah, again, something that you can either plan to do before you start the programme, or once you're in programme, discuss with your educational supervisor and your TPD. As a TPD, I've never refused anyone less than full-time training. It's very easy to ask for, and generally speaking, it's a specialty that lends itself to less than full-time training, as does medical oncology. So you should find that people are generally very supportive, and we have about just shy of 50% of our resident doctors at the moment on the programme who are less than full-time. So it is very common.
Thank you, Ruth. Are there any questions that we haven't answered, Michael?
So look, how much involvement do you have in radiotherapy planning, or is it mainly done by the medical physicists?
Right. Couple of our we've got our residents here. Rubab, do you want to answer that one? How much are you involved in radiotherapy planning?
So it's pretty much so. So when we rotate between the cancer sites, let's say, for example, I'm doing breast cancer at the moment. So we give it a go on every radiotherapy plan which the consultant needs have there on their list. So like I have a dedicated 2 sessions for radiotherapy planning, and so yes, I are very much involved. So all the plans that the consultant have there on your list, you are most welcome to give it a go to all the plans you have. And the reason of we publish the resident job planning is just to make sure that all the residents get enough time to try their hands on the radiotherapy. So, and it's honestly how much proactive you are and how much you want to learn radiotherapy, you can get involved in every step of the radiotherapy from planning aspect to when it comes to the physicist and approving the plan. I hope.
Thank you. Yeah, so we do the contouring, we say where we want to treat, the actual working out where the radiotherapy beams go. That is done by the physics team using very powerful computer programs. Obviously, we have some, we want to recommend where we want to direct them if we've got particular organs that we want to spare, that kind of thing. But the computing of the radiotherapy plan is done by physics. So thank you very much for that. We've got more questions coming in. Are we okay to carry on? Brilliant. Okay.
A question here perhaps for Satinder. Is medical oncology application self-assessment the same as clinical oncology? Does it account for 15% of self-assessment score as in clinical oncology?
So yeah, I mean, the application processes are very similar. Absolutely, between both specialties. I guess the difference that we have in medical oncology is that we look at, we have an additional part of the process when we're looking at the application. So we look at the commitment to specialty. So this is something that some specialties do and some don't. So we do score on the commitment to specialty ahead of time and then go on to the kind of evidence verification. So I think what's really important is that you find out, if you are wanting to apply to medical oncology, is that you talk to the medical oncology residents, you find out about medical oncology, you put your commitment forward, and any of us are very happy to chat to you about that, and obviously come to the webinar on the 10th and find out about that. Again, there's a supplemental question in there about the interview as well. Is it set up the same? In terms of the format. So yes, it does have the ethics and portfolio station. It has a research and governance station, and it has a clinical station as well. So slightly different, but again, we'll be able to go through that in detail at our webinar. And also, you can look at the ACP website and the JRC PTB, which is the training part of the RCP website, at the resources regarding medical oncology recruitment.
Thank you. Any others, Michael?
I think most of the others have been answered as we've gone through, and yeah.
Brilliant.
Looking, yeah.
Right.
Yeah.
Okay. Right. So, well, thank you so much to all our speakers. Thank you to the RCR team for helping us to host the webinar. We hope we've whetted your appetite. We look forward to seeing you, having you on board within oncology. I hope you're as enthused as we are. Thank you so much to everybody for joining the webinar. here at the bottom, there's a slide there. That's my my email address. That's an underscore between my two names there. If you want to ask any questions, that is the RCR Choose Oncology pages on the website there, on the RCR website, and we had the medical oncology webinar listed as well, didn't we? So lots of food for thought. Enjoy your careers in oncology, and thank you again to everybody.